Hello, and welcome to Beyond the Limb, where we explore physical therapy evidence, expertise, and innovation in limb loss and limb difference care. I'm your host, Will Riddick, and I'm a physical therapist focused on patients with limb loss and limb difference. I've often heard prosthetists and patients across the country looking for physical therapy practices that work with people with limb loss. The majority of clinics and rehab centers today don't necessarily specialize in one diagnosis, and so it can be a challenge to identify these specialty practices in limb loss care, especially as there's no current standard for specialization in limb loss and limb difference. So, for those that dedicate themselves to this patient population, they have an uphill battle to market their services and serve this population. Today, we're going to take a close look at a specialty physical therapy practice in limb loss care that has taken this head on. My guest today is Michelle Jamin, physical therapist and owner of Align Rehabilitation in Abingdon, Maryland. Her practice focuses exclusively on prosthetic training and amputee rehabilitation. A graduate of Elon University, she teaches prosthetics at the University of Maryland and assists with prosthetic coursework in the University of Delaware's DPT program. Michelle is deeply involved in adaptive sports and advocacy through the Amputee Coalition and APTA Maryland, working to advance care and resources for people with limb loss. Michelle, thanks for being here.
Thank you so much for having me. I'm happy to be here.
All right. I'm just going to kind of dive in here. Kind of give me a little bit about your background. How did you kind of get into limb loss, limb difference care? What led you to really want to focus on that?
My goal is to make this story under 2 minutes, so I'm timing
Okay.
myself. It's pretty straightforward. After 9/11 happened, my uncle re-enlisted in the war and he went back to Iraq and I was in the second grade when 9/11 happened. When he went to war, it was probably third grade. And it's just the way of life was the news was always on in our house. And I just remember seeing a video clip of soldiers rehabbing at Walter Reed with prostheses, and I thought, oh my goodness, that is incredible. That's what I want to do. And from really, really early on in life, I have always known this is the population I really wanted to work with. And I didn't know that the prosthetist was a thing. All I knew was, oh, it's a physical therapist teaching them how to use the device. So I didn't really know about O&P. I always questioned, like, would I have gone that route if I had known, or would I have always gone the PT route? But that was really it, like seeing at a young age, just being fascinated by the technology. And then with undergrad at University of Maryland, I was in close proximity to Walter Reed, so I got to do like observation hours there. And in PT school, everyone knew, oh, if it's something prosthetics, it's Michelle. And yeah, getting involved in the adapted sports helped me learn more about the population outside of the clinical setting. Uh, and yeah, it's just really been one step after another to lead me to where I'm at.
Yeah, I've heard that story about of uh, people not knowing about like being like CPOs, prosthetist, orthotist, and
Mhm.
like having that experience. I've often questioned that myself. I think if they could do just CP by itself, still, I
Yeah,
would
it used
probably
to be the
consider that
certificate program.
correct.
Yes, it used to be a certificate program. I think Northwestern is the only school that would consider our PT credits if that ever was something that we did. I love school, so I would love to go back. So well, stay tuned.
Fair enough. All right. Obviously, we're talking about this idea of specialty practices. Yours has come up in a lot of conversations I've had with some of just my general colleagues. Tell me a little bit about your practice, kind of like the overall model, or even if you talk about how it came about.
Yeah, so how it came about, I was working in an outpatient clinic, and then I transitioned to an inpatient clinic. And I had been working very closely with the gentleman who owns Real Life Prosthetics. Jonas Seberg is his name. And when I was doing my transition, I was like, hey, I have my LLC. I really want to continue seeing some patients on their side at home. Like I'm looking into this my own business thing. And he had said, oh, well, let's get together. Like, let's meet. And he really just shared this vision that I had of bringing to our community kind of like that one-stop shop of you go immediately post-op, you see the prosthetist, you start pre-prosthetic PT, and then just following this transition to optimizing outcomes. And it's just sounded too good to be true, quite like what he was proposing. He was like, you can utilize our facilities. He had an office in Delaware and in Maryland. When we're not in Delaware, you be there. When we're not in Maryland, you be in Maryland. Um, to really help get me going. And so that's where it started, just out of the kindness of someone's heart and seeing the shared vision that we had, helped me initiate Align Rehabilitation. And then one day in a prosthetist clinic, right? They're pretty small. They're pretty small, like just medical rooms. And I was trying to do a timed up and go. And I could see the patient pushing the walker, trying to turn, and just the narrowness of the door. I just said, this isn't a valid test. And I think I might have been hungry to make me snap, but I was like, this is it. I need my own space. I couldn't do the tug. And so the suite directly right next door to Real Life Prosthetic was open. I said, all right, we got to figure out how to do this. So I did eventually transition to my own building, but now we share a door, and that's how we can kind of cross collaborate with our mutual patients.
Got it. You kind of already answered this a little bit, but what was sort of like you mentioned that, like, yes, process office, a lot of them are quite small. Um, yeah, I mean, what was kind of like your initial driver to say like that it would be exciting to be in their clinic or be right next door to them versus like having a space that maybe you could customize a little bit more towards your own purposes?
So I would say that would be like the biggest, I don't, maybe like the biggest drawback initially was I was really only getting referrals from Real Life Prosthetics, right? A lot of the other prosthetists, there's a lot in the area, but they're a little territorial, and rightfully so, right? If their patients walking in through the door and it says Real Life Prosthetics, I'm sure that comes off strange. So it was a big driving factor for me to physically have my own building where it says Align Rehabilitation. You walk in and it's me, to help start driving the external referral sources. Um, and yeah, that has, I would say, like within my first year, a year and a half, it took me to get like 50-50 real life patients, and then the other 50% like outside community, like other referral source patients. But yeah, I wanted that so that I was a little more marketable, to the broader community.
Yeah. What were some ways that you were able to kind of reach out to the broader community? So my own personal experience, I used to work at a clinic that very similar setup. In order to go
Mhm,
to the practice that I was working at, you had to go through the office, a prosthetist office, to get into the building.
mhm.
And so, yeah, similar thing. Like you would very rarely get referrals from any other practice in the area. What did you do specifically to try to market that, to try to bring that to fruition?
So it was my my patients that were my biggest marketer. Like the patients would find me. They'd say, "Oh, I met so and so in the grocery store and they told me about you," and they'll start coming to me. So then, that was my first way of initiating building this trust, reaching out to the prosthetist and saying, "Hey, I met so and so." One of them thought I created the Power Knee. The Baltimore Sun did an article on me working with a patient using Power Knee, and the individual is a BK, and he called. I read this article in the Baltimore Sun. You invented this knee that drives people out of a chair. I'm like, no, 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 I didn't do that. I didn't do it. Um, but yeah, I mean, my patients have been, probably one of the biggest referral sources,
Mhm.
and then I'd say going to a lot of the like manufacturer sponsored events, like Oser hosted, a power knee training clinic with Bob Gailey at one of the local clinics, and I had gone there, and I introduced and I said, "This is what I do. Just so you know, though, if you do send me patients, they're going to walk in and it's going to say, yeah, real life prosthetics. And um, this was Art Molnar from MCOP, Maryland's Center for Orthotics and Prosthetics. And he goes, meh, that won't be a problem. I'm confident in my work. They're not going to leave me. I'm like, that's the confidence I need, right? If you want your patients to see someone, an expert in prosthetic rehabilitation, send them to me. If you want to send someone that's a K2 lower level technology, let me get them to a K3, send them back to you. You're making profit.
Mhm.
So yeah, just working to build that trusting relationship. Um, just showing that, I mean, I'm in this for the patient. I just happened to share four walls with other people in the profession.
Mhm.
Um, and yeah, I think right now I think I have more not real life prosthetics patients than I do their patients. So
Okay.
yeah, really doing well.
Yeah, it's effective. It's good.
Hmm.
Um, you know, you kind of mentioned this idea of that you were able to kind of like identify yourself as an expert in
Hmm.
limb loss care. Um, you also pointed out to this fact that it's like your work should speak for itself, and I think that's a lot of truth in the limb loss sphere, and a lot of like physical therapists are found because they are doing a good job. They happen to have a patient working with a particular prosthetist orthotist, and the relationship begins essentially. Um,
Hmm.
I was wondering, what is it? Was it the work that you were doing, or was it like special initiatives such as like these community events, like you talked about, that you felt like you were able to identify yourself as like specializing in this kind of care?
Isn't that strange? I still feel kind of like imposter syndrome because, right, there's not the actual clinical title. Um, but yeah, I mean, and you probably have done the same, seeking out any possible opportunity I could to learn and gain the prosthetic experience. And yeah, I guess just kind of owning it. Like, this is what I wanted to do. I knew it was very, very niche. Not a lot of people were doing it.
Mm-hmm.
So especially like very new in the beginning, telling the prosthetist that I had the interest, I want to learn. Can you help teach me?
Mm-hmm.
Um, that definitely was a good starting spot. And then I guess, yeah, as the experience came, just kind of rolled off the tongue. But I do still kind of feel like a fraud calling myself the expert because there's no certification.
It's true. I think there's a lot of merit, certainly, in being like an intentional collaborator, of like being here and being present, saying, "Hey, I want to do a good job with you. I want to be a partner with you in this process and to help out your patients." And I think that speaks highly for that for sure.
Yeah, and that's the advice. Like, I get a lot of people like message me on social media and be like, "How did you get into this? I'm really interested in getting into this. What do I do?" And that's what my number one advice is: find a local prosthetist, tell them that you're interested, right? They want to send their patients somewhere,
Mm-hmm.
but really there's not many of us. So if you can identify yourself as having just the interest, the willingness to learn, let them help teach you and give you some of that experience. Um, I think someone with an above knee amputation walks into the door. You haven't seen this since you read about it in PT school. Super daunting, right? So for the prosthetist to be able to identify, oh yeah, like I know so and so on Main Street. I've sent them a couple of patients, right? They're familiar, they want to learn, help try to and build that up that way.
Yeah. All right. I don't want to get too much into like business models or anything of that sort. That's a conversation for
I
another
probably don't
time.
even know the answer. I'm an LLC. That's about all I know. I'm just kidding.
But I want to know from kind of like a business perspective. I think
Hmm.
for anyone who is kind of going into the business sphere, it's quite a daunting process. Um, as far as like this partnership that you initially established, what were some kind of like key things that helped that from the business side?
So the initial partnership, all that was I was working rent free inside of the facility. So for that initial overhead was really non-existent.
Okay.
Now how it works, and I had been reading through like your little suggestions, is the sharing the office space. So no way in heck could I possibly afford my whole suite. So we did divide like the back suite they took over, and it's now their lab. So that helped cut my rent down considerably. Um, but other than that, that's like really only where the um as far as like I'm a separate entity, they're a separate entity.
Hmm.
We just work next to one another.
Got it. Okay. And we're able to kind of like split the cost basically via the space and keep
Yeah,
the overhead down.
in order for me to get my suite.
Yeah.
Yeah.
I think that's a really good way to enter into business too, is being able to kind of keep those costs minimal to be able to build up your model as time goes on.
Yeah, and they were able to, so we call like the the part their lab that's on my side, they call the clean lab. So that's where like all of the assembly gets done. That's where they do the
Yep.
poles, or the thermoplastics. And then their side is where you feel like you're at the dentist, right? You hear the grinding and all of that stuff. So they were able to expand while supporting my expansion. So that was really awesome.
Nice. That's a great way to do it.
Mhm.
I'm curious as far as what does your current practice look like? Is it just you? Do you have a front office person? Do you have a tech? Do you have other PTs? Tell me a little bit about
Um, I have a superhero office manager, tech, just Wonder Woman, and then I also do have a PTA that works for me part-time.
that. Okay, got it. So now, kind of coming back to the idea of this model overall, um, how right now would you say that you coordinate patient care? So especially as like, maybe if you had a patient coming in pre-prosthetic and they were
Mhm.
coming in through this process, what does that coordination look like? Both with your partner that's directly next to you, but
Yeah.
also with others in the community.
Yeah, so if it's with real life prosthetics right next to me, typically the patient will be in their clinic first before me.
Mhm.
And one of the providers will pop over to my side through the shared door. Hey, Michelle, we have a new AK. She'd be interested in starting PT with you. Do you want to come meet her? And then I'll be like, okay, I'll find time in my schedule and pop over for like the last 10 minutes of that appointment, and just kind of discuss next steps, looking at, all right, if you have this insurance, pre-prosthetic PT probably not going to be a thing.
Mhm.
And we make that initial connection. And then I would say if it was external, oftentimes the patients probably already have their prosthesis and then are reaching out. The prosthetist would make that direct referral and they would call and set up, like for initial gait training. And then a lot of times, or at least lately, the if it's external, the prosthetist will come in during a PT appointment, which has been really nice. As like maybe the visit number three, they'll come if there's any like alignment changes that I feel we need to do. And then if I have the time, I can also try and go and attend one of their follow-up appointments at the prosthetist office. But it's been really nice when they could come to me.
Yeah. Do you see patients other than just in prosthetic training at all? Like, do you see any folks for like orthotics, that kind of thing at all?
Yeah, and that's one of my big goals is to cover more of the orthotic arm too. So I do like a couple like post-stroke foot drops, but more of like the higher level neuro patients, like higher level gait
Mm-hmm.
impairments. Um, I don't have any experience with like spinal cord injury, but I would say like yeah, strokes. Um, I think how many? I think I have right now six non-prosthetic patients with like neurologic disorders.
Okay. Percentage wise, what is that for you?
Oh, yeah, you're like, what is that?
It varies widely.
15.
Okay, got it. Yeah, so it's still
Yeah.
pretty high, but it's nice to be able to fill
Yeah.
it in. I'm kind of curious, with other practices that were in the area. So, for example, like for me, I work in kind of like more of like a large rehab center that has a number of outpatient centers and very heavy neurologic focus, sees a very wide array of patient populations that can include folks with limb loss. Um, did you find that there was any kind of difficulty in basically identifying yourself as an expert with maybe some other, as compared to some of the other clinics in town?
Yes and no. There is a local hospital that does have another like, amputee specialist
Mm-hmm.
who is like a colleague of mine, right? Like we've done a lot of stuff with trying to initiate that initial petition for limb loss, right? So just like this wonderful soul, Dana Cross, she's an expert in the community. So that was I don't know. I never really felt any type of like competition per se.
Yeah.
I feel like it was because it was the big hospital system, like a lot of patients just try to navigate through that hospital.
Mm-hmm.
So maybe some of my patients are not from it's called Upper Chesapeake in particular, more like the John like from Johns Hopkins and stuff, but
Okay.
um I will say like one thing that I don't do very well is marketing. So I think if I was a little stronger on that, I probably would feel a little bit different in my answer and
Mm-hmm.
say, yes, I definitely feel I lose a good amount of patients to that hospital system. But right now I'm like, I don't know.
Yeah, but you're able to keep busy, able to keep up population of every, and yeah, keep it rolling. I think that's one of the things that I've heard from some folks in the idea of like creating specialty practices is like, will there be enough patients? Can I keep the
Yeah.
doors open? Kind of
Yeah.
thing.
Don't get me wrong. I mean, I so question that, but it's been a like a positive trend every month, right? We're getting new evals. Um, and then I think as I get more support staff,
Mm-hmm.
that marketing piece that I am lacking will improve, right? I'm not doing seeing my 8 patients a day, writing all of my notes, trying to make phone calls. Like I can delegate a little and then go visit a doctor's office and do some of that marketing. That's what yeah, I lack the most because I just, at the time's not there.
Yeah. Um, there's another thing I wanted to ask in terms of like clinic model overall. So you said you see about 8 patients a day.
Mhm.
Okay.
Yeah.
I'm just curious, like, how did you end up choosing that? I think I have an idea of what your answer is going to be, but how did you go about choosing that as compared to, uh, as we're all well aware, models are those numbers are getting higher and higher for most people nowadays.
Yeah, I mean, so my treatments are 45 minutes to an hour one-on-one.
Mm-hmm.
So there's only so much time in a day for me to stay sane and happy
Yeah.
and provide good care. Do I think I could treat 10 a day? Sure, but I want to be happy.
Yeah.
Um, and I mean, yeah, I understand why clinics are so volume heavy because reimbursement is horrible, right? So I can't say that I am rolling in dough,
Mm-hmm.
right? I live a very, very modest lifestyle with what type of paycheck I'm giving myself, but I just believe in the service that I'm providing. I know what I'm doing is meaningful and I'm not in it to make a huge profit. I'm in it to make a living, right?
Mm-hmm.
I want to be
Yeah.
able to provide for my future family. Um, but seeing 2 more patients a day, that's not going to make or break me.
Fair. Um, in terms of kind of clinical outcomes that you've seen as a result of this model, um, you've kind of worked in a few other settings. Tell me what's it been like to walk patients through a plan of care with this particular practice model?
Um, I don't know. I'd like to say that I see like things happening faster.
Mm-hmm.
Like, oh yeah, like absolutely, I'm cutting down um visit count by 10 visits because of X, Y, and Z. But I don't have that kind of data.
Mm-hmm.
That's something I would love to have. I would say um, just being able to streamline, okay, your socket's not fitting, you need to get a replacement socket, let's initiate that.
Yeah.
That definitely is happening sooner. Or, hey, you have this weird whip going on, let's get the prosthetist to do a quick adjustment, eliminate the whip in 2 minutes.
Yeah.
That's saving, like it's really saving the patients the headache of having to travel to and from different appointments. um I think getting the patients pre-prosthetically, that probably is where I see, if I was to do a comparison of the patients that I see after they get the prosthesis versus the pre-prosthetic ones, the pre-prosthetic patients are getting mobilized a lot sooner. I would say they're meeting their goals a lot quicker. Expectations are a lot better managed. That is something I find is quite challenging with this patient population. So yeah, if we can get that like just collaborative team approach very quickly,
Hmm.
then long-term outcomes I feel are improved, but I don't have tangible data to back up my statement.
Yeah, but at least you've kind of seen that, and you can feel that difference between different settings, and data comes as data comes. I mean, this is a hard population to track, anyways. I mean, they're full of comorbidities and what would be typical exclusion criteria for most research studies, anyways, which
Yeah,
makes it
this
challenging.
is true.
Um, Another thing, kind of in the coordination between for yourself and with prosthetists that you work with, um, are and this is something I've talked with another guest as well about the communication in terms of like K level. Like, let's say, like if you were going to do like an assessment of K level and communicating that to them, what does that process look like for you?
So I love this. This is so fun for me. I live by, so Meg Zions from University of Delaware has this paper out. It's titled, it's like selecting and administering outcome measures. And she has all population-based norms based on K level for very specific outcome
Mhm.
measures. So I will go through, I'll do like, yeah, the timed up and go, 6 meter walk, 2 minute walk, Amp Pro, um, or 10 meter walk, getting gait speeds, and have all of this comparative data present this packet of information on top of my Amp Pro. Uh, so yeah, that's what I will do. Did that answer your question?
Yeah, so you have like a packet that you come up with, and it has like all of the like a selection of outcome measures that you've assessed
Yes,
and
and
don't
then
communicate that.
I'll just write patient is ambulating at zero point 0.7 meters per second, consistent with K2 ambulation. I do see potential for K3 because they scored 38 on Amp Pro or something like that.
Yeah, yeah, and I bet they love it.
Oh yeah. I don't know if they read it, but
They
but
have
yeah,
it. The
I like to
documentation.
be very, very, very thorough with that stuff.
Yeah, absolutely. Just another kind of go back to one more kind of logistic question in terms of the clinic. Um, yeah, this is obviously it's your own kind of separate business, but how do you currently handle like the billing aspect, the documentation aspect, all of that kind of stuff, the real chaos of it all?
Yeah, so I tried to do my own billing for about a month and just no, I just couldn't do it. So I have a third party biller through well, I use Prompt EMR, which is like my documentation
Mhm.
system, and then they had recommended a company for that does third party billing. So yeah, she assists me with that. They take like a small percentage of my like monthly
Mhm.
income. So that's what, yeah, that's how I do with all that stuff. And then yeah, just my superstar Vicky is my superstar office manager. She helps do like all the benefits checks, eligibility checks, like all of that stuff.
Okay.
So that does save cost. I could technically pay the billing team to do that. But that was an added expense that didn't make sense when I have an hourly employee type of thing.
Yeah. Gotcha. Have you heard of other practices doing similar things to what you're doing?
Not insurance based.
Okay,
I know like cash based, maybe two. But yeah, taking insurance, no.
got it. You think it's because of the hurdles of like the billing aspect of it?
Oh, it's horrible. Yeah. Yeah, absolutely. Yeah, absolutely.
I moved from a small outpatient practice to a large rehab center, and so now there's so many things that I used to have to do manually. I say we have magical billing fairies that take care of it now.
Yes.
So
That's so
I know a
nice.
little bit about the small side of things and how much work goes behind the scenes for that.
Yeah, it's tough.
Um, yeah. So kind of one more question about this. What's been kind of like one of the most rewarding things as part of like building and working within this collaborative practice?
Mm,
No pressure.
I know.
Could be anything. Could be a number of things.
I know. It really can be. I don't I think just being able to, right, for our patients, this is such a vulnerable time for them. And to be able to have such a strong support system, I think like with our group, we have created, it's a Facebook group instead of a support group. My
Hmm.
patients, they didn't want a support group. They wanted like this, just this socialization group. So everyone joins and we go out and we do these community outings. And I think being a friend and not just a healthcare provider is, yeah, like just being so close with the other practitioners. I think that has allowed us to just build bonds with our patients that, yeah, you're not just a patient, right? Like we are so invested in your lives and we're all in it together. And yeah, we do things outside of patient care together, just building that relationship and, yeah, just helping return them to like a normal socialized life. I think that's been, something I've really enjoyed doing.
Yeah, that's really cool. It's I often describe my own patient. I talk to my own patients that I'm saying like, hey, like, more or less, your prosthetist, and for me, I hope to be your provider for life, more or less, and like to
Yeah.
continue on and be your go-to kind of person. But that's really cool that you're also like you're building community at the same time
Hmm.
with it too. That's really neat. My final question, I kind of like to bring this down to and just bring me any kind of specific patient examples. Do you have kind of like a story of like a single patient that, when you look at your practice that you've developed, that you're like, man, because I've done this one patient got to be able to do this thing. I know it's a hard one to pick from.
See, I'm so bad about like talking about myself. Oh, I would say one thing that's been really valuable, and especially having the prosthetist work directly next door, is when patients already have a microprocessor knee,
Mhm.
for instance, and they really want to try and get the C leg, right? They come in with maybe a lower tier microprocessor knee, and insurance is like, nope, you already have one. You don't need the C leg. And what we've been doing is I'll go through my whole list of functional outcome measures, performance-based outcomes with their initial prescription MPK, and then they'll come back in. The prosthetist will give them a loaner C leg, have them go home for a week or something. Even come to PT, train on it for a session or two, and then I'll redo all of that performance-based outcomes, show the side-by-side comparison, and say, haha, insurance, gotcha. Like we can prove that function is enhanced with this technology. Um, and like actually providing the evidence and having the patient get the better, um, component. That's happened 3 times in the past year, and that makes me very, very happy, right? Like we got to put people in the technology that's going to make them the most successful. Um, so yeah, that's been really fun. And just like those days I'll either see someone will do like 2 hours one morning with an hour in the morning with X, Y, and Z knee, an hour in the afternoon with the other knee. Um, those are fun. Like pretty like high level patients at that point. So it's pretty enjoyable.
Yeah, it's just a really cool to hear you talk about, being able to be an advocate to advocate for patients to develop community, but also give them that specialized care and that collaboration for their ultimate best.
Hmm. Yeah, it's a fun little life in Maryland.
Michelle Jamin, Aligned Rehabilitation. Thank you.
Thanks so much. Well, appreciate you.